Good evening. Thank you very much for joining us in this session. I'm Dr. Matawaran. I'll be discussing menopause, bones, bearings, and beyond. These are my disclosures. And for this session, our objectives are to illustrate a typical case of a patient suffering from symptoms of menopause. And two, we'll try to discuss management of menopause as to the following aspects, addressing menopausal symptoms and bone health. So we have a typical case of a 55-year-old newly diagnosed type 2 diabetics with 8-month history of menopausal symptoms characterized by worsening hot flashes, soaking night sweats, sleep disruption with fatigue that is affecting her work. She had a history of lactose intolerance. She was a previous smoker, but a non-alcoholic beverage drinker. Her mother suffered from colon cancer and had a history of hip fracture at 75 years of age. Her BMI is 19.8 kilograms per meter squared. So if we characterize her reproductive state, you will see that there are several consequences of menopause. And this menopausic stage is characterized by either early, intermediate, or late manifestations. So as you can see here, early manifestations at around 40 to 55 years old include hot flushes, sweating, insomnia, menstrual irregularity, and of course, psychological symptoms. Intermediate is characterized by vaginal atrophy, dyspareunia, skin atrophy, and urge stress incontinence, and is usually described as genitourinary syndrome of menopause or GSM. And the late consequences of menopause, of course, include osteoporosis, atherosclerosis, coronary artery disease, cardiovascular disease, and even Alzheimer's disease. So for this session, aside from GSM, we will be also discussing osteoporosis. And all of these manifestations, of course, is characterized by reduced quality of life. So we'll now go to the effects of menopause with regards to bearings or the way one behaves or conduct oneself. When you look at the overview of the different menopausal symptoms, we see that the central nervous system is largely affected by symptoms of menopause. And this, of course, includes vasomotor symptoms, sleep disruption, depression and anxiety, cognitive changes, and even migraine headaches. If you look at the staging system for reproductive aging in women, which of course is characterized by menarche and the final menopausal symptoms, you will see that during this time, that is after the reproductive stage among women, you will see that this final menopausic period is characterized by menopausal transition and postmenopausal manifestation. Sometimes the overlap we also call as perimenopause. And this is characterized by onset of what we call vasomotor symptoms during perimenopausal stage. And as we all know, up to 80% of women reported vasomotor symptoms, and this is why we consider that these symptoms is sine qua non of menopause. This usually occurs during the past 2 weeks and at some point during the menopausal transition period. It is also worthy to take note that there are 4 trajectories of vasomotor symptoms over the menopausal transition, and the patterns of vasomotor symptoms are heterogeneous across time. Some may have early onset, wherein vasomotor symptoms occur early in the transition that continued after the final menstrual period, but then eventually declines. There are later onset, meaning vasomotor symptoms peak at the final menopausal period and continuing, though declining into the postmenopausal years. Some may be completely asymptomatic, meaning there are few or no vasomotor symptoms throughout the menopausal transition, while others at the end or at the most extreme have what we call super flashers, meaning vasomotor symptoms started well before their final menopausal period that continued well into the postmenopausal period. In a meta-analysis looking at experiences and needs of Asian women experiencing menopause, it was noted that Asian women generally had neutral or positive attitudes toward menopause. Negative physical, emotional, and psychological experiences highlighted their unmet needs and unpreparedness for this phase of life among Asians. And among Filipinos, as you can see, top 10 common menopausal complaints among Filipino women, around 56.7% or more than majority, complaints of hot flashes, irritability, nervousness, and palpitations. So why do Asians usually undermine or dismiss vasomotor symptoms? So there are three common reasons why this is usually dismissed. One is that it is just transient. Um, Two, that it would only last for a few years, 1 to 2 years, and they are basically benign and won't hurt me. However, if we look at another study, this is the SWAN study, the study of women's health across the nation. It is a multiracial, multi-ethnic observational study of the menopausal transition among 3,302 women in the United States. It showed the contribution of menopause transition and midlife aging to women's health and well-being. So if you look at women at midlife aging, you will see that those characterized by the light orange bars are those changes driven by menopausal transition, while those at blue bars are the changes mostly driven by midlife aging. So as you can see, among women 50 to 65 years old. So again, in orange, you will see that vasomotor symptoms, hot flashes and night sweats, which is driven by menopausal transition, is highly characterized by midlife staging or aging among those 40 to 65 years old. And this is very important because it is really not transient, because again, in this study, we see that frequent vasomotor symptoms persisted for a median of 7.4 years, with even longer duration among other women. So as you can see in this slide, in this graph, you will see that it may last for more than 4 years, 14 years for some patients. So it can last more than 4 years with a long duration if experienced early in the transition. And vasomotor symptoms are associated with increased risk for chronic diseases. So that would include cardiovascular disease, diabetes mellitus, metabolic syndrome, fracture, non-alcoholic fatty liver disease, and and obesity. Because we also know that there are additional changes with menopause, and this is characterized by an increase in cholesterol, a reduction in good cholesterol, increased prevalence for hypertension, metabolic syndrome, hypertriglyceridemia, diabetes, obesity, and again, increase in waist circumference. And we also have to take note that women are basically different among men when it regards to cardiovascular disease among this age group, because women usually minimize their cardiac symptoms. Women seem to tough it out more than men, and studies showed that when men and women have the same severity of heart disease, women rate it as mild to moderate, while men rated theirs as severe. So as you can see, if you actually compare cardiovascular manifestations among men and women, there's really a difference between those manifestations among men and women. And in another analysis, you will see that women's early warning signs of heart attack weeks before the heart attack is usually non-specific. Unusual fatigue, sleep disturbances, shortness of breath, indigestion, and chest pain. And at time of heart attack, as you can see, you have their difficulty of breathing, weakness, etc. So that's why it's very important that we do address vasomotor symptoms among women, because as we also know that there are also gender differences in atherosclerosis among men and women, because women basically have smaller coronary artery disease, and this can eventually influence outcomes of angioplasty and coronary artery bypass. There are also lipid profile differences during menopause. As we can see here, there are worsening lipid profile among menopausal women, because of the increases in LDL, total cholesterol, and triglyceride. So that is why the development of unfavorable lipid profile after menopause can increase the risk of cardiovascular disease. And CHD differences in presentation in women compared to men, as you can see here, is really need to be addressed, and that would include, of course, symptomatology. And to relate that to menopausal symptoms, it says that in this meta-analysis, presence of vasomotor symptoms and other menopausal symptoms are generally associated with increased risk for cardiovascular disease by as much as 28%. So this is why in the 2020 menopausal hormone therapy guidelines, particularly for vasomotor symptoms, the reduction in estrogen levels in patients with vasomotor symptoms in the central nervous system may need treatment, and that would include menopausal hormone therapy that may be effective in addressing vasomotor symptoms. There are several forms of hormonal therapy for these women. That would, of course, include estrogen alone or a combination of estrogen and progesterone. Some may give your selective estrogen receptor modulators or your gonadomimetic, such as your tibolone. So tibolone is a gonadomimetic. It has tissue-specific effects. If you have your tibolone, it is metabolized. You have favorable effects to the bones because it decreases bone turnover. It may address vaginal dryness and reduce dyspareunia. It may improve libido. As well as some have endometrial effects. And we'll discuss later the effect on patients with regards to risk for breast cancer. Tibolone use significantly decreased climacteric symptoms during menopausal transition. As we can see in this RCT compared to placebo, you will see that the KMI or the Cooperman Menopausal Index, which measures menopausal symptoms at baseline compared to after giving tibolone, as well as the green total score, which also measures menopausal symptoms, you will see that there was improvement compared to placebo with regards to the reduction in this menopausal symptom scales, the KMI, the green total score. So this shows you how effective your tibolone is with regards to symptoms of vasomotor symptoms during the menopausal transition. In meta-analysis, including 46 randomized controlled trial evaluating tibolone for treating menopausal vasomotor symptoms in the Cochrane Library, we see that tibolone was more effective than placebo in reducing vasomotor symptoms. Also, if you look at the long-term adverse events with tibolone versus placebo in this meta-analysis, you will see that there was, as part of treatment effect, that there may be initial unscheduled bleeding, but with regards to stroke, cardiovascular events, venous thromboembolic events, and mortality from any cause, there was actually no increased risk with regards to these adverse events, and even no increased risk among women with no history of breast cancer. However, just like other hormonal therapy, this is not usually recommended among women with history of breast cancer. And this is why in the Endocrine Society guidelines with regards to hormonal therapy for menopausal symptom relief, we see that the recommendation states that for women with bothersome vasomotor symptoms and climacteric symptoms without contraindication, they suggest tibolone as an alternative to menopausal hormonal therapy. So they recommend adding against adding tibolone to other forms of menopausal hormonal therapy, and for those patients with history of breast cancer. So those are the two contraindications for the drug. In addition, in the 2020 menopausal hormone therapy guidelines with regards to tibolone therapy, it is noted that it is effective in alleviating menopausal symptoms such as hot flushes, vasomotor symptoms, and genitourinary symptoms. It is associated with a lower incidence of abnormal vaginal bleeding, as well as decreased breast density in mammography and reduced breast pain compared to estrogen-progesterone combination therapy, and could be used relatively effectively for treating sexual dysfunction. Could be effectively used for other symptoms such as mood disorder, sleep disorder, concentration disorder, and even fatigue. So in summary, we see that at least for the different studies for tibolone, that it does not increase invasive breast cancer and endometrial cancer, but when used for patients with breast cancer, the recurrence of breast cancer is increased. So make sure that your patient does not have history for breast cancer. It does not affect venous thromboembolism and coronary artery disease. However, in case of administering tibolone to patients aged more than 60 years, there's an increased risk of incidence of stroke. So just if we go back to our case, Amy, we will see that adding tibolone will be a very effective agent to address her vasomotor symptoms. So in the management of menopause, tibolone will be important in addressing your vasomotor symptoms. However, there are also non-hormonal therapy that may be needed by Amy to address other problems that accompany menopause, and that will be the use of bisphosphonates and calcium and vitamin D when we talk about bone health. Okay, so going back to Amy, remember that she had a family history of colon cancer, a hip fracture of her mother. She's newly diagnosed type 2 diabetic. Her BMI is quite low, and she has lactose intolerance. And these are very specific characteristics that increases her risk for what we call osteoporosis. So osteoporosis, as we all know, is a silent skeletal disorder characterized by compromised bone strength, predisposing to an increased risk for fracture. And bone strength is basically a product of bone density and bone quality. We basically determine bone health or bone density using DEXA scan or a bone densitometer, and we will see scores, what we call T scores, and they are characterized as normal, osteopenic, or osteoporotic based on their T score, -1 to 2.5 to osteopenia, or less than 2.5 or below for those patients with osteoporosis. So that's why very important, based on the APCO guidelines, the Asia Pacific Consortium on Osteoporosis, that we do identify patients at risk for osteoporosis. So you have there 4 steps: 1, 2, 3, 4. Okay, steps for the identification of patients at risk. So in this, it is very important, as one of the first step is to identify men and women with fragility fracture. Those who sustain a fragility fracture should be systematically and proactively identified to undergo assessment of bone health, and where appropriate fall risk as well. So fragility fracture are fractures that result from mechanical forces that would not ordinarily result in fractures. So a fracture sustained from a force similar to a fall from a standing position, or less, that would not have occurred in healthy bone, excepting fractures of the skull, face, fingers, and toes. So that if you're just standing and then you fall, you actually don't expect to be fractured. Okay, so that if you do fracture, that is called a fragility or a pathologic fracture. And this is very important, again, in the recommendation that you identify men and women with common risk factors. So those include elderly, 50 to 90 years old, gender, especially among women, of course, is a risk. Weight and height are risk factors. Those who are very lean are at increased risk for osteoporosis. Those with low femoral neck BMD, prior fragility fracture, parental history of hip fracture, current tobacco smoking, use of glucocorticoids, rheumatoid arthritis, causes of secondary osteoporosis that we'll discuss later, and alcohol intake of 3 or more units daily. So this is basically a unit of alcohol. So anytime you're taking more than 3 units of this, then that is already a risk for osteoporosis. We eventually assess for fracture risk and osteoporosis in postmenopausal women. So this is very important to establish, okay, in the history. Prior fracture without trauma after age 50, clinical risk factors, as you can see, we've mentioned this, history of secondary osteoporosis, risk for falling, and of course, height loss or kyphosis. So we can identify the risk for fracture by using what we call the FRAX, or the fracture risk assessment tool. So this is a web-based questionnaire wherein you just enter okay, several parameters no, to assess risk for fracture. So you just take if your patient has previous fracture, parent fractured hip, not just like, for example, for Amy, and you just take this and you will get, okay, a score. No? A score. Okay. And in this particular case, for example, a score of low risk is if you have a 10-year hip fracture of less than 3% or a 10-year risk of major osteoporotic fracture of less than 20%. If you're high risk, meaning you have a 10-year risk for fracture of more than 3%, and your risk for major osteoporotic fracture is more than 20%. So we'll use this facts tool later when we again evaluate Amy. So third step is identification of men and women taking medicine linked to bone loss and increased fracture risk. So there are anti-epileptic drugs, aromatase inhibitors, especially for those with prostate cancer, chemotherapy, medroxyprogesterone, glucocorticoids, heparin, lithium, proton pump inhibitors, selective serotonin reuptake inhibitors, SGLT2 inhibitors for diabetes, just like thiazolidinediones, and supraphysiologic levels of thyroid hormones are medications that will increase risk for fracture as well as bone loss. We also have to identify men and women living with conditions associated with bone loss, and that would include endocrine, nutritional, and GI conditions, disorders of collagen metabolism. You have here a list of secondary causes of osteoporosis in adults. You will see here that both type 1 and type 2 diabetes mellitus is a risk factor aside from hyperthyroidism, hypogonadism, and hyperparathyroidism. Alcoholism, calcium deficiency, vitamin D deficiency is also a risk, and other conditions are secondary causes of osteoporosis. We eventually try to identify those risks and establish those risks by doing laboratory examinations to rule out secondary causes. These are some of those basic laboratory examinations, and also identify the patient's risk for falling and fracture. So you have their neurologic disease disorders, impaired vision, impaired hearing, proximal myopathy, sarcopenia, aside from the medications that will increase their risk for falling. And that, of course, includes your sedatives, your antihypertensive, and of course, environmental factors that are really common sense with regards to increasing risk for fall, poor lighting, stairs, slippery floors, etc. So this is an algorithm. This is a mnemonic for you to remember osteoporotic risk factors: low calcium intake, seizure meds, thin build, ethanol intake, hypogonadism, previous fracture, thyroid excess, race, inactivity, and of course smoking. So that if you have those risks, there are some indications for you to do their bone mineral densitometry. So any woman 65 years old and above should undergo a BMD. All postmenopausal women with history of fracture, without major trauma, with osteopenia, starting or taking long-term systemic glucocorticoid therapy, and other perimenopausal or postmenopausal women with risk factors. So if you go back to Amy, you will see that she has actually some of those indications for BMD determination. So it goes without saying that when a BMD was done, it showed that her BMD score is between 1 to 2.5, which is consistent with osteopenia. So that if you will use the FRAX scoring even without the bone mineral densitometry, you will see that her risk for hip fracture is 1.2 and her major osteoporotic risk factor is 5.2, which is low risk. But if you will use Amy's, okay, BMD, her T-score is 1.5 osteopenic, you will see that her risk is likewise low. Okay? Low risk because because of the score together with the FRAX risk factor. Previous to the FRAX, we had the OSTA. This is osteoporosis self-assessment tool for Asians, wherein the decisions to start therapy is only based on the age as well as the weight of the patient. Okay, so that if, for example, your patient falls in the blue, in the green part, okay, of the OSTA, you will see that they have low risk or medium risk, meaning there is no need for therapy to start anti-osteoporosis therapy. If they fall in the red, they are high risk, then it is recommended that they should initiate therapy. So if we will use again the OSTA scale for Amy, she will be falling in the medium risk, so that they may be need to start therapy if you have additional one or two risk factor. So based on the 2020 AAC diagnosis of osteoporosis in postmenopausal women, so as you can see here, you may start treatment, or you may label patients based on the T-score together with their FACS score. So that, if you have a low-risk patient, very important in the algorithm for postmenopausal osteoporosis treatment based on the AACE is that you do measure for the T-score, evaluate for causes of secondary osteoporosis, but regardless of that, we have to correct calcium and vitamin D deficiency and address causes of secondary osteoporosis. Calcium, as we all know, is fundamental in any osteoporosis prevention or treatment program and part of a lifestyle for healthy bones at any age. There are specific recommendation, dietary allowances for calcium. This is from the Philippines. So if we go back to Amy, she needs 750 milligrams of calcium daily. There are other conditions, or there are other considerations. We have to remember that calcium absorption from carbonate, acetate, lactate, and gluconate and citrate, and from whole milk is actually similar, although calcium carbonate, okay, contains more elemental calcium per gram that I will show you later. Better absorbed when taken throughout the day, at least 2 times a day with 1 at bedtime, and calcium intake below the upper limits of recommended 2,000 to 2,500 milligrams is not associated with increased cardiovascular risk in generally healthy adults. Other practical considerations for calcium, remember that choosing the tablet form over milk would depend more on convenience of the tablet form and presence of lactose intolerance in the subject. Just like with Amy, we have to remember that 50% of Filipinos are lactose intolerant, so that if you have both parents with lactose intolerance, you have a higher risk of children also suffering from this disorder. So again, you have different calcium salts. So you have calcium carbonate, phosphate, lactate, etc. You will see that calcium carbonate has the highest elemental calcium content. So that if you'll be shifting calciums from carbonate to lactate, you have to make sure that you compute for the elemental calcium content. Okay? So aside from calcium, there's also important vitamin D with regards to bone health. So it plays a major role in calcium absorption and bone health, and may be important in muscle performance, balance, and risk of falling. And we all know that the major source is exposure of the skin to sunlight. However, there are also causes of vitamin D deficiency. Even in the Philippines, as we will learn later, there's inadequate exposure to sunlight. Wearing sunscreen with an SPF of 30 reduces vitamin D synthesis in the skin by more than 95%. Having dark skin tone also have natural sun protection and requires at least 3 to 5 times longer exposure to make the same amount of vitamin D compared to a person with white skin tone. And unfortunately, older adults at high risk of developing deficiency is due to the reason of the skin of these elderly individuals. They cannot synthesize vitamin D as efficiently compared to younger individuals. So common in patients with osteoporosis and hip fracture, so that you have to measure serum 25-hydroxyvitamin D levels in patients at risk of deficiency, because it can hinder effectiveness of anti-osteoporosis treatment if you have vitamin D deficiency. So that anytime your serum 25-hydroxyvitamin D is less than 30, then you are vitamin insufficient. So you have to have more than 30 to be vitamin D sufficient. And exposing 15 to 30% of the body surface area without sunscreen for at least 30 minutes between 10 a.m. and 3 p.m. Okay, may be enough. No? This is equivalent to consuming 340 to 490 IUs of vitamin D every day. Okay, so there are non-pharmacologic strategies for prevention and management of osteoporosis. We've mentioned use of calcium, so about 1,200 milligrams per day, or vitamin D, that's 200 800 IUs per day. So there are medications that are combined. This is very important among Filipinos because in the expanded nutrition survey by the FNRI, you will see that the mean usual intake of vitamin D by age group, no, in the Philippines is considerably very, very low. So these are the lines that are normative. And as you can see, this is the mean usual intake of vitamin D in the country. The mean usual intake of calcium likewise is very low. This is recommended and this is the actual intake. So you have to remember that osteoporosis medications are effective only if there's adequate calcium and vitamin D in the body. So last in the recommendation, again, depending on risk, if your patient in this algorithm is high risk, okay, then you may need to start, other than calcium and vitamin D, other therapies that would include your alendronate, denosumab, risedronate, and zoledronic acid. Also, in the Endocrine Society guidelines, it says here that all menopausal, postmenopausal women, if you have low, you need to identify the risk, low risk, moderate risk, very high risk. Then, depending on the risk, you may need to start treatment. So again, if you use, for example, for Amy, the OSTA, we said she is medium risk, then you may need to start treatment. And these are the recommended drug options for those to low to moderate risk for postmenopausal osteoporosis. As you can see here, alendronate or your bisphosphonate is part of those recommended because of the effect with regards to increased body mass in bone mineral densitometry, effect on vertebral fracture reduction, non-vertebral fracture reduction, and even hip fracture reduction. You will see here in this table, another table, again, this is from the AACE, American Association of Clinical Endocrinologists. You will see the data on reduction for fracture risk for both vertebral and non-vertebral fracture for your alendronate. So how do we give alendronate? It's given 70 milligrams once weekly to ensure optimum absorption. Take with a full glass of plain water only at least 30 minutes before the first food intake. So absorption is reduced when taken with other beverages or taken less than 30 minutes after other medications. So if we go back to the Endocrine Society algorithm, assess fracture risk, low, moderate, or high or very high risk. If your patient has low risk, okay, or moderate risk, then you may need to reassess fracture risk in 2 to 4 years. If moderate risk, you may start your patient on bisphosphonate, reassess fracture risk in 3 to 5 years, and of course, continue calcium and vitamin D therapy. So in summary, hopefully I was able to show you that vasomotor symptoms are associated with increased risk of metabolic and cardiovascular disease, that hormonal therapy, particularly with tibolone, reduces vasomotor symptoms effectively and safely in the appropriate patient, and that ensuring bone health is important, especially among those at risk, which means appropriate calcium and vitamin D intake and medications to eventually treat osteoporosis like alendronate, among others. With that, thank you very much.